Today we should be talking to Caroline Scott, a clinical scientist and the Video Telemetry Service Lead at Birmingham Children's Hospital. We should be hearing about how she helps prepare children affected by refractory epilepsy for surgery and the massive positive differences that her care and both regular and intracranial EEGs offer. If you're interested in learning more, keep watching. Also make sure that you subscribe and press that bell below for notifications of our future videos regarding epilepsy. Thank you so much for joining us, Caroline. Please, could you tell everybody a bit about yourself?
Thank you very much for having me. So I'm Caroline. I am a clinical scientist working at Birmingham Children's Hospital. My main role is I am the Video Telemetry Service Lead. So I am working with children who have refractory epilepsy and helping them through the pathway towards epilepsy surgery, helping identify where their seizures come from, performing video telemetry, both scalp video telemetry and invasive recordings as well. And that is my job.
How exciting. Well, I think it's really exciting. I think a lot of people go, oh my goodness, you know, she's talking about like intracranial stuff. What does that mean? But yeah, I mean, as I've had video telemetry, but luckily not intracranial, because my brain was shifty enough, obviously, that I did not need it. And they knew, take that dodgy bit out. Yeah. It's pretty obvious. Yeah. You're talking about children. So what age children do you work with?
So we work with actually all children. I think, so we work as part of there's a national network of centres, so very boring, but the government decided that organising the centres to make sure that the places doing this kind of surgery were centres of excellence, they limited it down to a certain group of centres that were allowed to do this. So there are 4 in the UK, so there's Great Ormond Street, there is Bristol, Birmingham Children's, and then there's a combined centre which is Alderhay and Manchester. And so all of us work as a little network and kind of split the country up, and then the children come from roughly the regional area to the centres. We're part of this little network. The Birmingham Centre is really big, and yeah, we're performing video telemetry for a range of patients who have refractory epilepsy, and it can be anything from days and weeks old to about 19 is the limit of when we can perform surgery on them, because there are certain types of surgery that really pediatric neurosurgeons specialise in, that even at the age of 18, 19, adult neurosurgeons wouldn't be as happy doing those surgeries because they're not familiar to them. They don't do them on such a regular basis because it is done more for paediatrics than anything else.
From the perspective potentially of a neurosurgeon, what would be the difference between somebody who's 19 and 20 then? Why would you need a particular type of, like an adult or a paediatric neurosurgeon on each side? How do they differ?
For adults, you're looking, this is very broadly speaking, I'm not a neurosurgeon, let's just get that out there. Very broadly speaking, for adults, the surgery tends to be more temporal lobe epilepsy. It tends to be the one that is done most often and is what adults tend to suffer with on a more regular basis. So that's the more standard operation. For children, they're extratemporal, so they're outside of the temporal lobe and can quite often involve a whole hemisphere. So things like doing a hemispherotomy, where you're disconnecting the 2 hemispheres so they can't talk to each other in the same kind of way, is an operation that realistically a paediatric neurosurgeon would be much more experienced at doing. And some of our children up to the age of about 19-ish still need those kind of operations, the quite drastic operations, and therefore wouldn't want to be handed over to adult care because it just wouldn't be something they'd be comfortable doing. So we have transition services where the children, if we've identified a lesion, an area of brain, we can hand over all of that information to the adult services if the patient feels like they'd rather be in adult care or they want to take a little bit more time, or some of our children have said, actually, you know what, I'd like to get through uni before I do that. So we hand it over to somebody else who will be experienced at doing that kind of surgery. So it isn't a hard and fast rule. It's just, it's something we play by ear when they get to that age.
So what do you actually do, though? Because you've got like this wonderful title and stuff. Well, titles plural if anybody's interested. But what do you actually do? What do you do for these children and families?
My job is essentially children come into the epilepsy surgery pathway. They've got refractory epilepsy, so as I'm sure many of your avid followers will know, that children as well as adults, once you've tried probably about 2 anticonvulsant medications, the chances of another one working is pretty limited. So for these people, in actual fact, surgery could be an option, especially if they're having focal seizures. So what our job is to try and identify where the seizures are coming from. So on a weekly basis, I get children into the hospital on a Monday. We stick a whole load of electrodes on their head. We monitor them throughout the space of a week, and we try and capture their seizures on video and EEG. And so the two things are so important. Essentially, the EEG is going to tell us where the electrical activity is coming from, and then the video is going to give us subtle signs about the bits of the brain that are involved. So we're looking at minute little details like which arm move first, which way do their eyes go, do they do some pouting? Is there any dribbling? Do they look scared? At what point is these happening? Are they occurring in a certain phase of sleep? And in it, there's so many tiny little details that we find really important, and they help just localise where the seizures are coming from. So for some of our children, their MRI scans look completely normal. We send most of our children for PET scans as well. Quite often they come back normal. And the EEG and the seizures that we're seeing are the only things that are guiding us as to where they come from. And so for some of these children, we then have to go for an intracranial recording. So say we can say, we've localised it to this region. We can't be that general for surgery. It has to be as specific as we can be. So we're trying to make sure that we're taking the smallest amount of brain out that is going to stop the seizures, but is also not going to have any impact on the child, or limited impact.
When I had my resection, I know there was still some shifty tissue left, because the impact, removing that would have an awful impact on the tissue next to it. So do you have to do that sometimes with the children and explain that to the mum and dad as well?
Absolutely. So part of doing the invasive recordings is that as well. So in some of the children where we know we've also got a lesion, but we know that lesion is actually butting right up against something that's going to be really important, we put electrodes into the lesion, round the lesion, front and back, and then we can map what those bits of the cortex do. So we can do specific tests and make sure that is exactly what we're finding from those bits of tissue. And in some cases, if you've got a lesion that's an abnormal piece of tissue, it can actually push the function into other areas if you've always had it. So that therefore means that in actual fact we could take it out when anatomically looking at it, it looks like it should have been doing something useful, but that function has actually shifted to a different area of the brain. So a lot of what we're doing when we're doing intracranial recordings is not only localising exactly where the seizures are coming from, but is making sure that the areas around that lesion, we can then essentially demarcate an area to the surgeon and say, well, this bit, you can take this bit, but not any further than that, which is something that we can also explore in theatre as well.
I've always considered myself a bit of an anomaly, but we were chatting before this, and I said that I was excited about my own surgery. Yes, I'm a supposed adult, but even as a kid, I was like, whoa, brain is so amazing. And I just know I would have been quite excited about it. I did trust my clinicians as well. But we've been speaking about how lots of parents, they get really nervous about, oh my goodness, you're going to take a bit of my child's brain out. Should they do it? But can you tell us why they shouldn't necessarily be so worried?
Yeah, I mean, understandably, you're going to be worried. I mean, it's a big undertaking. I think the thing I always find absolutely remarkable is how quickly children recover from this kind of surgery, literally bounce back. And in a way, I think that's something that a lot of parents put themselves in that position and go, oh my God, this is going to be terrible, this is going to be awful, and the child's going to feel dreadful. In actual fact, the children do a lot, and they tolerate it a lot better than anybody anticipates. The thing I think is the most important thing is yes, it's going to be, it's going to be several weeks off school. It's going to be, a week in hospital, a lot of recovery, maybe some physio. It kind of depends where we're taking taking the tissue from. But at the end of the day, if that can lead to them having no seizures, or, you know, even still on full medication, that they're still on fewer seizures, shorter seizures, the impact is so great that it's just that, like, the children just come on in leaps and bounds. And I think for a lot of parents, they get so used to their child having so many seizures, and a lot of smaller children have seizures in their sleep, so their sleep's disrupted, their learning's disrupted, they're on anticonvulsants which don't help their learning either, and it's just that, you know, everything compounds everything else, and it's just to have that burden lifted a bit, and just their brain, they just excel, and you know, it isn't the case for everybody, but giving them the chance to do that, I think it is just, it's just something that realistically I think a lot of more people should be helped to make that decision, and to see that it can be so productive, especially for children.
You're making me just like go all soft. I think that it's so true. You know, like if I'd have, for instance, had surgery when I was younger, I know that, well, first of all, the scar tissue most likely would not have grown even bigger. I wouldn't have had all the accidents that I've had. I would have been on a lower dosage of anti-seizure medications growing up, so I would have been able to pay more attention in school, not fall asleep all the time, have more friends. And also with lower dosage of meds, you know, we know those can sometimes contribute to psychiatric comorbidities, which I experienced as well. So I sound like I'm really trying to sell it, don't I? I just think it's really bad.
Yeah, absolutely. But I mean, as somebody that's gone through it and can see the impact that it has, to know that, you know, for some people that option is available to much younger, and for, you know, for the children that are under, that we see that are under 5, I mean, we operate quite quickly because, you know, their brains are so plastic, they recover so well, it's like it never happened for some of them, and that is just amazing. And to be able to do that and offer those children and like an escape almost from a lifetime of having seizures is just, it's something that we all strive to do, and really, like, having parents on board makes that so much easier.
I guess it's like the education of parents is so important, because the more you realise, the more you understand what your child might be going through and what the potentials of treatments are, the less scary it is. And also, I think if you understand or have a good understanding of the pros and cons of a surgery, I reckon more people probably go down that route. A lot of the time, it's the stuff, the comorbidities and the drugs can be worse than the epilepsy for the child. Yeah. And I think that's not often seen by other people. And so to just be able to tell that stuff, to, you know, sod off a bit, that would be amazing.
Yeah, absolutely. And I think some of the amazing things that, you know, I've experienced at work and have just really made you realise how difficult life is with epilepsy. I mean, thankfully I have never had a seizure, and you know, touch wood, I won't ever, but we had 2 teenage girls in. I try and get children in that are the same age at the same time, so that then they've got something in common. And so then I had 2 teenage girls in, and one of them had literally never met a single person who had epilepsy, and the relief to meet somebody else who knew what she was talking about and knew how difficult stuff was. And like, to be 13 in general is pretty awful a lot of the time, and just to meet somebody else who was used to the idea, like, she kept missing school because she had seizures in the morning and she couldn't then get up, or she had to sleep for the rest of the day, just have someone else who goes, yeah, been there, done that, and like the 2 of them exchange numbers, and they're still friends to this day, and it's just lovely. And I think we've then tried to instigate a teenage support network through the psychology team as well as through us, to give them a bit, like, just to have somebody to talk to that gets them, because like teenage kids don't always want to talk to their parents, and they want that independence.
Or anyone.
Well, true, but they want that independence for their parents, and quite a lot of parents don't really let them have that independence just because it isn't safe for them. And it's just so difficult, and just having that kind of freedom to make some decisions for yourself, I think, is really important. And sadly, some kids, you know, suddenly start having seizures in their teenage years, and it, you know, the whole world gets turned upside down. And rather than growing up with this and knowing that this is them and part of their identity, they kind of have to reform their identity around the idea that they have seizures now, and that can be so hard. And to be able to offer them the opportunity of taking that away is just even better.
Be like another universe for them, like seriously, like not even another world but another universe, because your life, especially if you're somebody who is being considered for surgery, your epilepsy is refractory, it kind of, even if for instance you're not having tonic-clonics, and you're not injuring yourself frequently, that doesn't mean that little rude word is going on in your head and that is affecting the whole of your life. So do you know what? Interesting. You've made me think of somebody that I know. We've been friends for a very long time. And I found out that she had had epilepsy whilst we were living together, but she didn't know. And I didn't know. She was having nocturnal seizures, and she had been having them her whole life, but I didn't know. And it was when something unusual occurred. She woke up and she's like, what is going on? And she got diagnosed, and they said, yeah, you've been having this since you were a child. And whereas I was like going for it all the time with my tonic-clonics and stuff, and she was being a great friend, like, oh yeah, and she was having her own. It's not funny, but yeah, it's not. No. But yeah, and she takes, so she wouldn't consider surgery now, and she's like me, a supposed adult anyway, which is different, not your patients, but she the drugs that she takes they don't have a massive impact on her life because she's on quite a low dosage, and that helps her out, and that's amazing. And I think it's important to recognize that we do have people who, like, good on you, like it is a restriction in life to a degree, especially if your seizures aren't controlled, but it's not so bad. So not all kids and not all or supposed adults have it to the nth degree.
No. And but like you say, not everybody has like massively disabling seizures. It's just the wider impact that those seizures have, and the medication and the impact on everything else that especially for children is so important. And you know, the memory capabilities and things like that if you can help that at all, it makes such a huge difference, I think.
I was thinking recently that, so I'm quite, I don't know, over the top when it comes to certain words, even though I can hardly remember them half the time. But and I was thinking about, wow, what if I had been, I call it doped up, but on anti-seizure medications earlier than the age of 10. The learning opportunity that, say 2 years earlier, those from 8 to 10, I wonder if I would have learned far fewer words. And even today, communicating could be even more challenging. So it's like the earlier you are able to help that child, the better, right? Reduce the seizures, get rid of them if possible, and then I would totally have considered surgery myself, but that is just me. But
yeah, and it's one of those things we're trying to make sure everybody has access to, and right. You know, we do a lot of work going to obviously in the current climate we don't go anywhere at all, but virtually going to other centres and saying, you know, these children, though you may not think of it, like if they meet these criteria, it's worth us having a look, it's worth us doing these investigations, doing a more complex MRI scan, doing a video telemetry, capturing their seizures and being really certain that we know what's happening, and to see whether that is an option, even if it helps, you know, choose a better medication or something, you know, try a different combination that you haven't thought of, or something along those lines. It's really disheartening when people go, well, you know, you've got refractory epilepsy, you know, that's it, you're going to have seizures the rest of your life. I feel like there are some places where people still get managed like that, and I don't think that should be the case. As you say, it is perfectly possible to be on medication, to have occasional seizures, and to live a fulfilling life. But if we can get in there and help to start off with, why not give it give it that go. And like we have a lot of children come through, and you know, at the end of the day we go, actually, you know, we could offer this, but these are the chances of X, Y and Z happening. You know, if we took it out, you know, you might end up with this kind of deficit, or you might end up with one arm weakness, or word finding difficulties, or memory problems. And then, you know, at the end of the day, that kind of decision is very hard for a parent to make on behalf of a child, especially a child that possibly doesn't have the greatest understanding of what's happening. But the team are really great at being very honest about what they can offer and what they anticipate will happen. And our neurosurgeons will give you a percentage chance of seizure freedom. And that's part of their kind of laying out all the evidence. They're going to go, this is what we've got. This is the evidence that we have. This is the chance of seizure freedom. And you know, ask your questions now, and we'll do our best to answer them. And I think, from that point of view, I feel really lucky to work as part of such an amazing team that do this on a regular basis, and have such a wealth of experience of successful surgery. It's brilliant.
What are the titles of the other people that you work with? Because you say team, but who does that include?
So the team involves neurology, obviously. Neurosurgeons, we have 2 neurosurgeons at the moment. We have psychiatrists, physiotherapists, neuropsychologists, speech and language team, occupational therapy, and us, and radiology. There's quite a lot of us.
Yeah, it's so important. I did a presentation recently, actually. It was like kind of a pie chart, but without any specific percentages. But just to try and explain to the audience how, yes, you need people in all the roles that you've just mentioned, much especially if one is going through surgery, but in full care of somebody, especially with such a complex disease, you need to be able to have the support. Like, I think often people think about surgery, okay, cool, that's great, no more seizures, oh my goodness. Or even if they realise it's no more seizures, often, you might not be rid of all your seizures. That often there's, you know, psychiatric comorbidities to deal with, or learning difficulties, or, you know, and it doesn't necessarily mean that those issues will be there forever, especially with kids, right? You can mold that amazing brain tissue and just learn some other way. But
yeah, absolutely,
it's pretty amazing.
For some of our older children, you know, and they experience this quite a lot in adult centres. If you've had seizures all your life, that identity of I'm somebody with epilepsy, I'm somebody who has seizures, changing that identity can be quite a struggle, and it's quite a mind shift. And I think a lot of people think, oh, you know, you must be delighted, and you're just like, I've got to reshape myself now. Like, I was told all of these things wouldn't be options, and now maybe they are. Maybe I can go to uni, maybe I, you know, can do these things. And I think from that point of view, the cohesion of the team is really great. I get to spend a week with these children, and their parents, like chatting to them every day, chatting to them about their seizures, getting to know, you know, what their aspirations are, and that kind of thing, and understanding their capabilities on a day-to-day basis, and also getting a really good idea of their seizure burden. And that is really useful information. It's all very well, I can say where the seizures are coming from, but also kind of being able to give feedback about, you know, over the course of a week, this happened, or we've really felt that this was an issue. And, you know, we get the psychiatrist to come and see them where they're in if we have concerns about them, and just having those resources available is really invaluable, I think. And like you say, it is a massive team of people, and we can't do it without any one of those people not being present and engaged for that child.
It's lovely to hear you talk about your colleagues as well, because I'm pretty sure that most of the people affected by the epilepsy's, families included, unless they kind of come to the point where they're considering surgery for their child, you just see your neurologist, and sometimes maybe you'll see the child's epilepsy nurse, but that's about it. And they don't really know of all these great minds coming together behind the scenes to help them make the decisions that they need to for their child. There is so much work and knowledge that goes into it. And actually, speaking of knowledge, tell us about how you are constantly learning, because you do so much stuff, and technology is taking us in like amazing places, and all this research and stuff. You must have to like flip and read like 5 books a day or something, right?
Yeah, and I wish my poor memory could keep up with the amount of stuff I actually have to do.
Oh, I feel you.
So yeah, I think that's the thing, and you know, we work in a field that is, you know, it's clinically driven, but we are research focused as well. So each person in the department also has, you know, their own little bit of research that they're doing. We have loads of different bits of software we use to analyse the data. So the parents and the children see us doing an EEG, and then, you know, for several days in a row, and then, you know, they kind of get some feedback at some point later down the line, and they kind of, like you say, they kind of forget all of the stuff that goes on in the background, all the analysis that we do. And when it comes to the intracranial recordings, I mean, we are doing hours and hours worth of analysis, and, you know, we have got computer programs that analyse the spectral quantity of the EEG that you're recording at different points in the recording that indicates exactly where we think the seizures should be coming from. We do all these stimulation protocols and send signals down the electrodes and try and stimulate seizures or stimulate different bits of brain, check the connectivity between different areas and map out networks. We do all of this in 3D as well, so we can map the electrodes on a 3D model of the brain. So we use loads of different bits of software and analysis tools that lovely nerds sitting in labs in universities all over the world provide us with, and it's great to be able to use these tools that have been so dedicated to research in a clinical setting, and, you know, add these into the whole wealth of knowledge that we have. And for me, I'm quite visual, so for me, being able to see electrodes in 3D space, I mean, obviously most of the time I'm looking at a page of wiggly lines, to then be able to, with intracranial recordings, to be able to then see that in 3D space and then go, actually this one relates to that one, and that's why I'm seeing that discharge on those two electrodes, even though they appear to be a long distance away. When they actually inserted, they did this, and they're actually millimetres apart when at the point I'm looking at it. So there are so many things that we're getting up to in the background that, yeah, there aren't enough hours in the day to fit in the amount of nerdiness that we like to get down with, to be honest.
Well, I truly admire nerdiness, should you call it such. I just think it's amazing. And while you were describing that, and I can't think of the word for what I'm about to say is, but you made me think of planet Earth, right, in space. And then you've got, I'm thinking of the poor countries that are on the edge of the tectonic plates, and they're going to have a... yeah, I know, but it is kind of like this, right, isn't it?
Yeah,
and then so they're going to have an earthquake, yeah? And so there's a little bit of a rumble deep down, like 10 miles down, and then it's coming up and it's going to go psh. And it's a bit like when a seizure goes off, that earthquake, and then it could go even further. Say it goes across like a tiny island and it causes a tidal wave, and that could be like your tonic-clonic, secondary generalized tonic-clonic. And I don't know why you made me think of it like that, but it is kind of like that.
It's a really, really great analogy. So for some of our patients, they don't really understand. Quite a lot of kids, we often see their seizures are so deep that when we're doing a scalp recording, we barely see anything. Yet we know, looking at what they're doing, we know hands down it is clearly a seizure. And it's that understanding, and, you know, the professor I work with has so much experience, and we'll just look at it together and go, well, it's clearly a seizure. Where it's coming from, we need to try and work out, but we know that's a seizure. And so this is our hypothesis, and we'll come up with a list of like 3 areas we think. It's probably this, but it could be that, and maybe it's spreading to here. And that's how we then plan the implantation. So when we don't have anything else to go on, if we've got a normal MRI, and even if the video telemetry looks fairly normal, you're just getting indications of where things are coming from. Often it's across like the vertex of the head, so it's come from somewhere really deep, and you're just literally getting a radiation up to the surface, and that's all you're seeing. And so you've got to get these electrodes really deep inside the brain and work out exactly where, like you say, these little eruptions are coming from, and why we're not seeing them spread to the surface. And the amount of times we implant these electrodes and that bit of brain is firing away all the time, and you're just like, it is just going for it, and then every now and again it is just spreading a tiny bit further out.
It's pretty amazing.
Yeah,
it's horrifically amazing, but yeah. And you're making me remember there was a conversation I was following online. There seemed to be quite a lack of understanding of EEGs, which is basically that if one has an EEG, no matter one's age, then if there's any abnormal or extracurricular tectonic activity going on in there, then that will be identified. And I was like, wow, okay. Now I probably thought that when I was little too, but like personal experience, I've had EEGs which were like totally fine, nothing dodgy there. Even first video telemetry, second one, I was so stressed, then I had a seizure, which is the only time you want one. But I think it's quite common to think that one EEG will be all good. And that, so if you could just, well, what you are telling us is that is certainly not the case.
Yeah, and I think, you know, from our point of view, in the more routine element of the department, we have a lot of children that will come in for a first EEG. They've had, you know, a couple of seizures, you know, maybe in kind of, maybe they've had a high temperature and that kind of thing, but there was something unusual about the seizure and therefore it warrants an investigation. And we'll do an EEG, and like you say, it turns out completely normal. So we then, you know, that it's the old adage of sensitivity and specificity. We need to then try and change those numbers round and make sure that we are getting the most useful information. And so the yield of an EEG goes up significantly, the length of the EEG, and also when you include sleep. So for a lot of our children, and to be honest, in our routine department, pretty much anybody under the age of 5, we actually do a sleep EEG on. Not only because we can make the EEG longer, we can also, it's easier for small children to be asleep. Yeah, and so you can just, like, you've got the electrodes on, you annoy them a bit, they maybe have a bit of a cry at you, and then hopefully they drift off to sleep, and you can then let the recording run for 40 minutes, an hour, and get a lot more information. And that transition between wake and sleep is when you do see a lot of abnormalities. So we often then do the really mean thing where we let them sleep for 20 minutes, half an hour, and then wake them up so that we see both.
You are mean, man.
We are.
Oh
we are
gosh.
mean. It's how we get down. So you see those two transitions, into sleep and out of sleep again, and that increases the yield of an EEG even further. So the longer the recording, the more data you're likely to get. So it isn't to say that if you've had a normal EEG, I'm saying everything's abnormal and you just don't know it yet.
Of course.
But if you're absolutely convinced, and if the as a parent, most parents will come in and go, that's not right, something's not right, I know something's not right, and that is usually your indicator that something unusual is occurring. And especially if somebody's seen it, I know it goes against all the laws of looking after somebody in an emergency situation, but getting your phone out and videoing a seizure is one of the most, I know, but it's one of the most useful things you can do. And especially if you know it's coming, like if your child or the person you're caring for gives you any kind of warning, that initial stage is the most important bit, because that tells us exactly where it's coming from. So yeah, things like that can be really, really helpful. And I think, the longer recordings we do, I spend my days doing week-long recordings, so I'm all in favour of a longer recording, but the resources of the NHS don't allow us to do that with everybody. So we have to pick what we feel is the best recording at the time. And for a lot of centres, that will just be a routine EEG, but you will find, especially for paediatrics, they will do a lot of sleep EEGs, because that just gives us a bit more information.
How do you keep the kids calm and stuff when you do it? Because I know lots of mums and dads get worried, oh my goodness, you're going to, well, first of all, just an EEG, you're going to touch my kid's head and it's going to, my poor child is going to freak out or whatever. And sometimes they do, especially with, you know, I'm stereotyping, but certain types of autism and stuff, they don't like it, and which I totally get. So how do you help that be okay for the child, like less stressful?
We do encourage parents, if they really know that their kid really doesn't handle having their head touched, to let us know. So when they get the appointment letters, or they know they're having a referral for the test, to actually say, actually this could be really tricky, and it gives us a heads up, and it also enables us to incorporate things that might make it easier. For some of the children, we for most of the children that have a sleep EEG, we give them melatonin, which is a natural hormone, and it enables them to be slightly more sleepy. For kids that sleep quite deeply, you can get electrodes on when they're asleep.
Wow.
Yeah.
Despite the scratch, that is pretty deep.
Despite the scratch, we are like electrode ninjas, and we can get them on. But for a lot of children, in a way, it's going to sound a little bit cruel, but smaller children, getting them upset and them crying actually wears them out a bit. So then once you've got them on, they do go to sleep really well. So if you can handle 10 minutes or so of them being a bit agitated, annoyed at us, we can get those electrodes on and they will drift off to sleep. For children that are more autistic, of which we do see a lot, understanding what might help them and calm them down is great. We have little TVs and DVD players in our rooms. We have a lot of relaxing music that we play. We can give them extended time slots. We encourage people that, especially that really struggle with the idea of being in hospital, to just come in and see the department first. We have a really brilliant learning disabilities team. They have sets of electrodes, disposable electrodes, and they sit with the kids. They go through what it looks like. They get the kids to stick them on dolls, stick them on other people. So for children that we really do need to get that EEG done, we have a lot of ways of kind of reassuring them that something, it may not be brilliant, but it isn't A, going to last long, and B, it isn't going to hurt. And just giving them that reassurance is really vital. And for a lot of the children, just really taking the time to let them settle into somewhere, settle into a room, understand what's happening, understand that we're not a threat. It's a long-winded process, but it is definitely worth it.
Having that insight into how your child, what is going on there, and if you are, if you are able to understand a bit of yourself, just knowing what the person is doing, and there's no threat, and actually it's pretty cool. Because I don't remember having my first EEG, but I just know what I'm like, and I was like, so why are you doing that? Why? How can you see in my head? I don't understand. Why? And that is what kids do, isn't it? It's questions, so if you can answer, I still do it, to be honest, but yeah.
But yeah, all the questions, like the amount of stuff we get asked.
What's the craziest question, or like most unusual, should I say, question you've ever been asked?
The most frequent question you get asked is, can you read my mind? Which honestly, if I could do that, I would be a lot richer than I am right now. Yeah, can you tell what I'm thinking? Yeah. And for some children, especially, if they're a little bit misbehaving, you say, well, I can do, and I'm not going to tell you, Mum. But no.
What's the reaction when you do you say that sometimes? That is funny.
Okay, I'll do whatever you want.
But well behaved.
It's having a joke with them and getting them to kind of know that, like you say, I think a lot of children have the opinion that doctors and nurses and medical staff are kind of, they're scary or threatening or difficult. And being able to just sit and have a laugh with a kid and get on their wavelength and know what it is that would make them laugh, or just get them to relax is really important. And it does make the test go, if you can extend that recording from 10 minutes to 20 minutes to half an hour, it makes all the difference.
Do you ever do ambulatory EEGs with patients?
Yes.
How does that work, your side?
We get the patients to come in, we stick all the electrodes on, glue them down, have a little box that's about this big that they take home, kind of old school Game Boy size, and they take that home. Yeah, million wires, which we wrap in kind of like a sock bandage so you don't get in a tangle. We've got special hats that have a hole in the back. So it's like a swimming hat, a fabric swimming hat, hole in the back so that electrodes come out of it, and they're all really cool shapes and colours and all that kind of stuff. So the kids really like them. Oh,
that's so not fair, because I had one of those, right, 2 years ago, and I'm not a child, but it's really not fair because I had one of these, right, and I'm taking my pack home, which looked really daggy, by the way, anyway, and I had I just thought, I had no special hat or anything. It was just like some, the dodgy wires hanging. I did take a picture and put it on Facebook because I thought it was quite stylish, but yeah, see, the kids get all this cool stuff. It's so unfair.
Absolutely. So that on the whole, that tends to go pretty well. And yeah, we run a service where we get them to come to us, so that we get them to come back every day. I know some of the other centres get equipment couried out, or they go to the houses, but we don't do that at our centre. And we also do a time-locked video as well, so you can take the video home and set that up. So kids that are having overnight seizures, if they have them every night and they're going to be much more settled in their own home rather than in a hospital bed, we get them to put a camera by the bedside that links to the ambulatory recording, and then we download it all and work out what happened overnight.
So much of this was not possible just a few years ago. I think it's really exciting, and having like you and your colleagues over here, but also who work with people overseas too. That's really cool, because you can learn from each other, right? And you don't all have to read 4 books a day. Do 2, and then just share the contents with everybody else.
Yes, absolutely.
Thank you so much for being here. It's been real, honestly, delight talking to you, and really just so heartwarming and cool to hear how you're working with these. I didn't know what to say, children or families. It's kind of both, right? Because the epilepsies affect the family so much.
Yeah.
Thank you.